Welcome back to Dr. Health's channel. Today we have a very, very special video. I've got with me one of the best injectors I've ever seen, and I rarely compliment people, as you know. This is Amrit Tiara. Amrit, thank you for coming today.
No, thanks for having me, Abs.
And we have a very special subscriber of the YouTube channel. This is Mark. Mark, thank you very much for coming today. And what we're going to do is show you in real time what happens when we do dermal fillers. Not, a single area, like a little bit in the nose or a little bit in the cheek, but we're going to try and do a full face, which is much, much more complex. And it should give you much, much more dramatic results as well. And Amrit's an absolute legend at this. He's taught this all around the world. He's even taught me a couple of years ago. And I'm going to let him show how an expert does exactly this. So Amrit, what I'd like you to do is, first of all, we've got Mark here. Yeah. His skin is all nice and numb. Yeah. I'd like you to talk me through what you see. He's happy to replace the volume that he's lost over the years.
Really.
And he doesn't want to, look slightly different. He wants to look like his own self.
Yeah.
Correct me if I'm wrong. So talk to me about what you see and how we can achieve that.
Absolutely. Now, I had a little chat with Mark off camera before just to kind of work out his goals and what he wants to achieve. And that's exactly what he said, Abs. And he doesn't want to look like someone else. He just wants to look good for his age, and like Mark did when he was maybe 5-10 years ago, when he had a little bit more padding on his face, a bit more youth on his face, and he feels that that's kind of prematurely aged, mostly as a combination of just life in general and the aging processes. But Mark's now in his 50s, and what we want to do is trying to work on making him look good for 50s. Ideally making him look like he's in his 40s while he's in his 50s.
Yeah.
So when I had a look and I had a chat with Mark did something really interesting. I wanted to see if Mark can do that for me and the camera to explain what he did to me, because this is something I see a lot when patients come in, and the typical thing they do is they understand the concept of facelift and they do this.
Yeah.
But Mark went one step further. He just made it phenomenal. Mark, can you show us this?
Hard without a mirror. But
yeah, have a go. Yeah, it was really good how you did it, because it kind of showed me a lot about his expectations, and I could then understand what I can realistically do.
Okay.
So Mark was able to kind of pull back the skin laxity to show me kind of the smoothness he wanted to kind of achieve on the surface levels. Now, I'd let you relax more, and that kind of shows me quite good what he was trying to explain. For me, that kind of showed he wants to make everything look fuller and tighter.
Okay.
And assessing his face, I can kind of see there's a few areas where it almost looks skeletal. It almost looks very skeletal now. I can see he's looking quite gaunt. He's lost a lot of volume.
Yeah.
And the classic areas I see that is generally volume loss in the forehead, even though he's lost volume in the forehead, isn't as noticeable as it is around the midface.
Yep.
In the midface area, I can see the discrimination between the eyelids and the cheek junction really clearly.
Yep.
Now, when the eyelids start to separate and the cheeks start to kind of then also hollow out, you start to get this kind of pattern, which we'll talk a bit more about in detail maybe on the podcast, is the false tear trough approach, where his eyelids now are looking like they're protruding because the cheek has now stepped back.
Yep.
So he has a flattening of the anterior cheek, where the maxillary bone now has kind of almost become concave. There's no padding in front of the maxillary bone.
Yep.
We're able to see the zygomatic arch and the zygomatic bone very, very prominently, which is kind of giving him almost bony skeletal effect.
Yep.
But because there isn't a seamless transition between zygomatic bone, maxillary bone in the anterior cheek, and the orbital rim, all of these look like three separate areas.
Yeah.
So the way I kind of tell patients is that it's a jigsaw puzzle, this piece, that piece, and this piece. They all fit together.
Yeah.
But right now, they're not fitting together.
There's got to be a smooth transition from one to the other.
That's it, yeah. So the light reflex now isn't doing Mark any favors. It's actually then highlighting the areas separately and not merged together.
Yeah.
And a simple test I can kind of do is, it's a very crude test, but I can just use my fingers to start pressing these areas out.
Yeah.
And I can see one of the hollows and the shadows starts disappearing just by me bringing the anterior cheek up.
Yeah.
So normally patients lose some volume and the remaining volume kind of falls down.
Yeah.
Because of skin laxity, and also just the soft tissue is not adhering to the bone as much anymore.
Okay.
But now what's happened is he's just lost all of it altogether, to the point where I know when I'm going to go and treat this area, the distance from the skin to the bone is going to be minute.
Yeah.
Like I'm going to get my needle in.
And can I just explain what that means to viewers, because that might not make sense.
Yeah.
When we put a needle into a particular place, and Mark, I'm just going to use my finger as a needle. When we inject here in that particular place, we expect to go through the skin, and then we expect to make contact with the bone. Now, if there's, quite a youthful appearance and there's quite a lot of fat present, what happens is the needle has a distance to go through that fat and then hit the bone. So there's some distance and time. When someone has lost the fat and the skin is much closer to the bone, we'll make contact much, much quicker. That's what you're referring to, right?
Absolutely, yeah. So just by examining the distance there with my fingers, I can kind of see we're talking it's pretty much just the thickness of the skin.
Yep.
Next to no padding.
Yeah.
Tiny thin layer of muscle.
Yeah.
And then we're talking onto periosteum or the bone itself.
Yeah.
So that tells me two things. One is that a little bit of volume will make a dramatic change. So I don't need a lot of filler here.
Yeah.
People assume when you have a lot of volume loss, especially with Mark's volume loss, a lot of filler is going to be needed.
Yeah.
A little bit of filler in each area will make a dramatic change. It's on how you
agree.
use the filler that makes the difference and where you place it. So the goal isn't to just puff up or volumize his face globally.
Yeah.
It's instill a very targeted approach.
Yeah.
So I want to use the least amount possible.
Yeah.
Pretty much as much of it onto the bony surfaces so I can kind of lift the soft tissues all the way from the bone and use a thicker, high density filler that will last longer.
Yeah.
It will be harder to migrate because of the thickness, the consistency of it.
Yep.
So it gives you the longevity and the good cosmetic results with less actual amount of filler needed.
Yeah.
But the thing to be cautious of is because I haven't got a lot of skin and soft tissue to hide the filler under.
Yeah.
Because the skin is pretty much on the bone.
Yeah.
It's easier to mess up because then you've got the filler sitting right under the skin.
Yep.
But it's on the bone.
Yeah.
I can't go any deeper. I can't hide it under any more layer. So it's that analogy. There's that kid's story, that fairy tale where there was a princess who had
That's under the pea.
the pea
Under the mattress.
and that's it.
Yeah.
They still feed it under 7 mattresses. I mean, you could hide a pea under 1 mattress.
Yeah.
Right? You had 8 mattresses. She's phenomenal how she could feed it, but you would be able to hide filler under that many mattresses quite well.
Yeah.
Mark's now literally got the 1 mattress and I'm hiding filler under the 1 mattress. There's not a lot of room.
Yeah. So I guess in that situation, do you feel as though it's better to, and I personally do think this, but do you think it's better to consider the whole face as one?
I agree.
Yeah.
That's it. So for me, I'm looking at all the jigsaw puzzle pieces.
Yeah.
So that's kind of the most common presentation that patients see.
Yeah.
But Mark was able to kind of talk about the other wrinkles and lines he's kind of seeing where the skin is folding all the way through the buccal area.
Yeah.
But when he did that, it shows you that he's got temporal volume loss.
Yeah.
So that's an area we're going to start with.
Yeah.
Got volume loss in the anterior cheeks. Volume loss around the orbital rim, the junction between the lid and the cheek.
Yep.
He's got volume loss in the buccal area.
Yep.
Periform fossa.
I agree.
Around this chin shadow area.
Yep.
In the chin, pre-jowls, along the jawline itself.
Yeah.
Pretty much all over.
Yeah.
All the way through to preauricular sulcus. So
yeah.
I'm looking at it globally. So I'm not then just fixing one area, which will then make the other areas look highlighted or missing.
Yeah.
So if I kind of just run it through a crude
kind of
drawing approach, if I just turn Mark towards me this way here, Mark, that's on me. So if I have a look, this is a transition from his frontal bone of the forehead into the temporal fossa. So this is kind of roughly where that starts. We can start to see the concavity here. Then I can see the zygomatic arch and I can kind of see a really good transition over here. So if I just turn him the other way, we can kind of see that nice embossing there, which shows me that there's decent volume loss there.
Yeah.
So just addressing that alone will help the areas below, including the eyelid positioning as well. So that'll help with the brows.
Yeah.
If I turn him back towards me this way as well. So then I'm kind of looking at the mid face. So if I just mark up some Frankfurt lines, I can start to then also appreciate the way the lateral cheek looks very prominent. So I don't want to add anything there. A common mistake a lot of injectors do is they just treat the cheeks.
Yeah.
And the only cheek they can do is the lateral cheek because it's easy, right? And that's the way they're taught. So in Mark, if I did that, he's already very strong there.
Yeah.
It would only accentuate the missing segment in the front here.
I think it would just completely change his face shape as well. Always sort of a diamond shape.
That's it. Yeah. It would give him a bit of feminization almost.
Yeah.
Oh, yeah. So if I just now mark down the mid cheek groove along the orbital rim, just over here, and then we can kind of see these other volume loss grooves just from expression and the skin having very little volume behind it. So the analogy I like to think of here is a raisin. So a grape is very full of volume. As it starts to then lose its volume, it becomes a bit more wrinkled and as a raisin. Not necessarily that because the membrane on the outside of the grape has become lax. Mark probably hasn't had that much skin laxity as much as the volume loss is kind of.
I agree. I mean, if you look at the jawline here, there's not really a jowl.
That's
It's
it.
actually got a pretty decent jawline, so I don't think it's a skin
The
problem.
volume loss is kind of giving him a bit of a chiseling, if anything, isn't it?
Yeah.
It's overly chiseled. And the youthful aspect, this is what I kind of say, when you look at a baby,
Yeah.
they're just full of volume. They just have a lot of volume. And we squidge it, we play at it, and all these things, and we find that cute, but you can't see their bone structure.
No.
They almost look like they have no chin and no nose.
Yeah.
And you can't really see their cheekbones.
Yeah.
It's only really as we mature into young adults do you start to see that. And then we have this kind of, we become adolescents and adults.
Yeah.
And then as we start becoming mature and older adults, that's when we then lose the balance and we lose the chubbiness and is replaced with boniness. So if you think of a 70, 80, 90-year-old, it's just bonier, isn't it?
Yeah.
So too much bone is not good.
Yeah.
So you want some padding, but padding in the wrong areas also, especially if you look at those saggers when the people have skin laxity, lots of volume. That's such a difficult thing non-surgically for me to treat. So I would categorize Mark as a pure sinker. He just everything is sunken. He's lost all his fat pads. Yeah, he's lost some bony tissue. So we're just trying to replace that. But I have very little skin laxity to worry about,
which is a good thing for us.
Yeah, absolutely.
Makes our life easier. So we're looking at quite a lot of different areas, and we're looking at the temples.
Yeah,
we're looking at the sort of front of the face, the front of the cheek.
That's it. Yeah.
And then this area, which we call that the buccal area.
That's it.
It's just an anatomical term, not buckle as in belt buckle for those watching.
So I'm just highlighting in a bit of brown kind of areas where we need to revolumize. So I don't want to put anything in the eyelid because it's already strong. It's the fact that the areas below it aren't merging in along into this area, buccal area, where this is a bit more of a challenging area to treat because the anterior cheek, the time we have bony planes to go into and make contact with and fill off.
Yeah.
But over here, if we just open your mouth a little bit, Mark, inside here, there's no bone. It's just basically I'm in the oral cavity, isn't it? Yeah. So I don't have anything to project the soft tissue off.
Yeah.
And now sometimes when people have this, I like to examine their teeth structure because teeth kind of flesh out your face. And I see people have missing teeth and that makes the cheeks cave in.
Yeah.
But I'm sure with Mark's case, it's more of a case of just this fat pad of diminishing because the buccal fat's not as prominent anymore. So that'll be a different approach to volumize that, which I'll kind of demonstrate as we go into.
Okay.
And then just the kind of more bread and butter stuff, the piriform fossa is just hollowed a little bit, not as much as in some patients you see.
Yeah.
But a lot more of the hollowing is kind of happening in this kind of chin shadow area where he's got some strong areas and some hollow areas. So it's a little bit more targeted visualization where he's going to go. A little bit in the chin, some recession over here, so we can bring this structure out as well.
Yeah. I think the pattern of volume loss here is actually very standard. Yeah. And it's very normal.
Yeah.
And we see these areas together needing volume at the same time quite a lot, don't we?
I mean, the classic kind of stereotype I'm kind of going to deduce here is I've been seeing this a lot in the last 6 months.
Yeah.
Mounjaro phase, Ozempic phase.
Yes. Yeah.
Dramatic weight loss generally presents in this kind of pattern where they start by the anterior cheek diminishing, the eye area looking quite aged, and then things start to shift and the labor folds starts up here, then the pre-jowl, chin shadow, all that sort of stuff disappears, and then the buccal kind of the temple volume loss is last. But that's kind of the typical pattern I see when they've lost, I don't know, 1, 2, 3, 4 stones. It just progressive.
Yeah.
So it's become now this full face jigsaw puzzle that I just can see it very clearly.
To predict exactly what they need.
That's it.
Yeah. Cool. So I think we're all done on this section.
Yeah.
We will see you guys very shortly with Mark lying down. Welcome back. And what we've done now is we've sat the patient down and Amit's drawn some very fancy drawings on the skin, and he's going to talk us through what we're actually seeing in these drawings and why it's important for you if you're ever thinking about getting dermal fillers. I'm going to talk us through these works of art that you've done.
No problem at all. So the most important game changer for me when I started my practice to where I am now has been understanding facial vectors, understanding what projects out versus what concaves in.
Yep.
And when those two separations happen, they can be positive, beneficial, or negative. Now, when women apply makeup, for example, they try to accentuate this. So
like highlighters and shadows and things.
Highlighting on the cheek and darkening under the cheek, highlighting on the bridge of the nose, darkening on the side of the nose, all these other things. Under the neck, darker, lighter on the top of the jawline. So the brighter stuff makes it look like it's sticking out or more chisel, And the darker stuff casts a shadow. So when I see those differentiations between positive and negative vector, we want to bring that into a positive light. I want to give Mark's face all the light reflexes are good and youthful, such as along the cheek and the front of the cheek and the nose bridge and the chin and the forehead.
Yeah.
But I don't want any of the negative ones where things start looking too sucked in.
Okay.
So it helps me choose where to place filler based on what's gone in, what's gone out. So on the one side, if I just turn Mark over to the side over here, like I can see the temporal hollowing over here quite clearly. And then below it, the green is all basically the negative vectors, the things that have gone in.
Yeah.
The blue are the positive vectors, the things that are sticking out.
Okay.
Now the cheekbone on the side should stick out, but this shows me that I don't need to add anything more here because it's already very positive.
Okay.
The bits around it are negative. This is what's giving this an overly bony appearance.
Yeah.
Is the buccal hollowing, the anterior cheek hollowing, and the temporal hollowing. All these three areas around it have disappeared in. So I need to bring them out to sit, not flush with this, because this should still be the strongest, but to sit and blend and transition much better.
I think what some people don't realize is if something looks like it sticks out, it's not that it necessarily sticks out. It's that things around it are not sticking out.
Have gone in. Yeah,
exactly.
That's it. So that's these three areas, the kind of common areas, and then the peripheral fossa, the top of the nose over here has gone in as well. Typically, normally people have quite a lot of hypertrophy of this nasolabial fat pad and it folds over.
Yeah.
So this isn't as strong as it is typically for a lot of patients. For Mark, this is less strong.
Yeah.
But I still don't want to be adding anything to this because that's a negative area to add volume into. And you see that all the time when people are filling the nasolabial line and they end up migrating the filler into this. And
it just looks like Homer Simpson after a while.
It does. That's it. So the eyelid, again, I don't want to add anything into. A lot of patients are misled into eyelid treatments with skin boosters, polynucleotides and volumizers into the eyelid because they think the eyelid, although it looks like it's a problem, it's actually the area below the eyelid that's not supporting the eyelid very well.
Yeah.
And then again, the chin area. This is a common area where people will start to see this folding of the marionette line, the resorption of the chin shadow, this kind of mental foramen over here. Everything just kind of disappears into the area. And then they start to get a recession of the chin, a little bit of a jowl, a separation of the pre-jowl, so they get a bit of a hollow over here.
Yeah.
And all of that mismatch is actually generally the chin resorbing in while the jawline is just staying put, a bit like the lateral cheek. I always find the jawline and the lateral cheek stay put and everything else seems to resorb in was around it.
Yeah.
So the green areas we want to bring out, the blue areas we want to leave alone.
Yeah.
But the thing to then also consider is I can't just go in and add a gel in without risking blood vessel problems. So
of course.
I've marked up the blood supply major branches. So if I just turn Mark towards me this way.
So those of you that are thinking about getting fillers and you've heard horror stories about blocking blood vessels and people going blind, it's not made up, like it's true, but it's a risk that's incredibly controlled. And, you know, there are certain things we can always do to make sure that that's as low risk as absolutely possible. For example, understanding your anatomy, using ultrasound, things like that. So what Amrit's done here is he's drawn where we all know, anatomically speaking, the major things to avoid are these blood vessels. So talk us through what you're seeing here.
Absolutely, Mark. So being an intensive care doctor by background, I used to work in the neck a lot, putting neck lines in, central lines and stuff like that in intensive care. So this area is an area I've scanned a lot. And over the years, I've then moved my ultrasound scanning into the face to better understand the anatomy here and how variable it is from person to person. But the thing that never changes, even if someone's had a surgery, implants, trauma, fracture, all these kind of things, is the depth of the vessels. The vessels might, side to side, but the depth or the plane that they run in this under the skin doesn't change. That's really important to understand. So for example, the facial artery, the biggest one that comes into the face, is deep, and then it starts running more superficial along the nose. So when I'm placing filler around here, I can't go deep to the bone as safely. I have to use different instruments like cannulas you'll see me using shortly. Some areas a needle onto bone with contact is the best approach. But a park and push approach, where I'm just parking my needle and then pushing the gel into the face, I need to be cautious, knowing that if I'm going to do that, I haven't got a large artery nearby. Or I can use other mitigating things by reducing the amount I'm using a smaller bevel, moving my needle around a little bit so it's not all going into one pinpoint position. Or I can go into a superficial plane with a cannula to then soften transition. So some areas are no bone, like the buccal and the peripheral area. So these areas I have to use a cannula. The temporal area, I have a bone, but I have lots of blood vessels in this area. So I'm going to use a mixture of needle in some places where it's safe. And then a cannula in areas where it's a little bit more uncertain where the blood vessels might be. So I can use a blunt instrument to safely fill. But roughly these purple lines represent the kind of, these kind of triangular lines are showing where I'm going to be using a cannula. And the circular dots are where I'm going to be placing a needle onto the bone with contact to then project off with filler. But the goal is mostly to use all higher density fillers and minimal lower density fillers, which are more prone to migration over time.
So you go with the high density, much more lower down. Yeah, so it's mimicking the high density tissue like bone.
That's it.
And then lower density, we go more superficial or more shallow, if you like.
Yeah.
So if you hear the word superficial in anatomical terms, that means shallow, and then deep obviously means deep.
Yeah.
And if Amrit talks about something being anterior anatomically means towards the front of the face. So coming up here. And then lateral means to the side, and posterior means as we're going back, just in case you hear those terms. So I think we're ready to start injecting.
Yeah, that's it.
Cool. We'll see you in a second.